Okay, so without further ado, let's hopefully make breastfeeding simpler. Okay, so let's set the main premise for this course, which is when breastfeeding challenges occur, sometimes the problem is not with the mother's technique, but rather with the baby himself or herself. Barriers within the alignment and tone of the body, causing abnormal function and preventing normal breastfeeding. So why do I say it that way? Well, I work closely with many IBCLCs, which for the layperson in this class, that stands for International Board Certified Lactation Consultants. And I have similar training myself. What they do is so very needed and helpful. Lots of times help with things like proper latching, nursing positions, and others fairly simple things help to get feeding off to the right start. There's so many things in the scope of the lactation consultant that can improve breastfeeding success. However, sometimes, even after all of that great help, things just still don't work. And when that happens, that's the time to look at the baby itself. The majority of breastfeeding dysfunction on the part of the baby is caused by imbalances in their own body that prevent them from doing what nature intended. And we're not just talking about tongue tie here. We will talk thoroughly about that a little bit later. Anytime that things like positioning and other interventions on the part of the parent just isn't quite right or isn't quite resolving the challenge, then again, we have to look at the baby. So I'm going to quickly do a fun exercise to bring this point home. What I want you to do is turn your head over to the side. Okay. Now I want you to rotate your head. Curve your chin, tuck your chin down. Okay. And at the same time, bring your shoulder up to your ear. It's kind of hard to do, isn't it? Now, I want you to imagine, stay there if you will. I want you to imagine now that you've just been squeezed through a birth canal and that maybe this process took a day, 2 days, 3 days. Maybe there were hours of pushing. And maybe you have also a cone head. You have a actual distortion of your head itself. And let's not forget that with that long and traumatic birth, that unfortunately, studies have shown that that gives you the equivalent pressure on this delicate, tiny little neck as a severe car accident, whiplash injury. That is the sobering fact. Think about that type of tension and trauma and even soreness in your neck. So again, we're uncomfortable. So my point is, obviously, do you think you can open your mouth, suck, and swallow very well? Probably not. So let's move forward and find out more about what's going on. Here we go. Let's talk about the latch. That is the subject that everybody is talking about. That is how this baby is going to feed or not going to be able to feed effectively. So as you can see here, picture on the left, yes, the picture is of a beautiful, very effective latch. The baby's mouth is open nice and wide. His mouth is covering most of the areola and the bottom lip and chin are dropped way down. We can assume here that the jaw is also wide open. This placement brings the nipple deep within the baby's mouth, allowing for the transfer of milk from the ducts deeper within the breast tissue. The baby can also use his tongue, hopefully, to squeeze the nipple up high against the palate to achieve a vacuum seal and to elicit the sucking reflex. In this position, when the milk is ejected, it is passed easily down the baby's throat for a normal suck-swallow ratio. Beautiful. This is what we want. Now the picture on the right, not so much. Let's see what's going on here. This is not an effective latch. The baby is not opening his mouth wide enough to cover the areola or to engage the deeper breast tissue for a better milk transfer. The baby is only able to get the nipple into his mouth, probably causing pain and possible nipple damage to the parent. In this case, you might see the blanching on the baby's lips or the blisters as he is trying to use all of those superficial muscles of his mouth to suck the milk out of the nipple, but not very effectively. Okay, so the nipple is not placed deeply into the baby's mouth, nor is it reaching the palate for that needed seal or reflex stimulation. Now, where that slide ends and where my brain keeps going is why the second baby can't get the proper latch, why can't he open his mouth wider, and why can't he use his tongue normally? Now, this is a picture of a beautiful latch. We can see the bottom lip dropped way down, actually the bottom and the top. We don't see much of or any of the parent's areola in the mouth. And we can just hear those nice rhythmic sucks and swallows. Everybody looks relaxed and happy. This is a beautiful latch. So bottom line in our discussion today, to make it simple, there are 3 things that your baby must be able to do for successful breastfeeding. Number 1, open the mouth for a wide latch. Your baby's jaw and mouth, same thing mostly, must be able to open wide enough to cover most of the areola in order to access the milk ducts in the deeper breast tissue. If your baby can only latch over the nipple, feeding is ineffective, painful, and can cause nipple damage like cracking and bleeding. Let's talk about why that might be. Now, we're going to go through just some very simple anatomy to explain the function or what the necessary function of the baby. I'm an anatomy geek. I love this stuff. I absolutely love connecting the dots and explaining the functions of the body through the anatomy. So I'm going to keep this simple. Some of us in the room know this anatomy, some don't. So these are at least the exterior, the main cranial bones that we're going to be discussing today. One of the most important ones here is this orange bone in the picture. That's the temporal bones. We've all heard of the TMJ. That's this here where it meets the mandible, i.e. the jaw. That is the jaw right there, the union of those two. We're going to be talking a lot about the occiput. That is, in this picture, the green one at the base of the head, and the maxilla is another really key player for us. The maxilla is the hard palate. If we were to, and we will, when we see different views of the maxilla, we'll see how it all fits in with all of these other bones, and meaning that the alignment is crucial. Here's a picture if we were to kind of open up the skull and see the interior of it from the underneath level. So in this diagram, these temporal bones are red, orange over here, but these are the same bones as we look at the interior of the cranium. Both sides, they anchor this bone here, which is called the occiput, green over here. I couldn't find 2 models that were the same color, so you'll have to bear with me. Here's the occiput here. You see how it is completely connected interiorly to those temporal bones. And this one right here we're going to talk about later. This is called the sphenoid. That is an interior bone. Again, you can see that it anchors the temporal bones and the occiput. On here, you just see that sphenoid sticking out at the side a little bit near the jaw and near the eye socket right on the side. But it is an interior bone in the cranium. Okay. Now, talking about the jaw. Now, I'm not going to go through ad nauseum. The main point here is that it is muscle attachment to the tongue. So We do need it obviously to open nice and wide for the latch. And again, look at where it's connected. It's connected to the temporal bone and it's connected to the bottom portion of the jaw, the mouth, which is called the mandible. Okay. And look here, this is what I'm always reminding. We're going to talk a little bit more about that subject of the tethered oral tissues later on. But the main muscles of the tongue are connected to the bottom of the mandible, interiorly right there. They're connected to the temporal bone. There's a little, what's called the styloid process, the little bump that's on the side of the temporal bone. And they're connected into a bone that we're going to talk about later on too, that is in front of the upper neck. It's called the hyoid bone. And so again, if you think about the little exercise that we played in the beginning, where we cocked our head and we're in a really strange position, which often sometimes happens to the babies, this temporal bone very often can rotate out of place, causing the jaw also to go along with it. And you can see here how it would, quote unquote, tether those muscles that are connected to the tongue. Okay. Let's also look at some of the other muscles of the jaw. Again, for the take-home message of the structure has everything to do with the function. These are the main muscles of the mouth and some of the muscles that the baby used to be able to suck. Here's another main muscle of the jaw here. And see again how they're connected to those cranial bones that are very pliable, that are not fused as a baby, and do move quite a bit through the birth process. I like this one. Again, I'm an anatomy geek. We're talking about one called the medial pterygoid. That one is actually connected not just to the exterior, but it goes back into the interior of the cranium and attaches to that sphenoid bone that we saw a moment ago. What does this look like? This is just one example. I have 1,000 pictures that I could share with you, but this is an example of a little guy that you can absolutely see this going on. You can see the divot on, it's the right side of this picture, the left side of his head. What that is, if you can imagine, is that temporal bone that we saw a few slides back. You can go back and look at that if you need to, is actually rotating towards the center internally. And imagine here, I'll go back for a moment. Imagine what that will do to the jaw. Again, this is rotating internally towards the center of the cranium. And you can just see how that's going to pull up that jaw on that side and very likely cause dysfunction for this little guy being able to open his mouth nice and wide. The other thing we see here is that he is turning his head. This is a head tilt over to his left, and you can see that his shoulder and his neck are pretty much glued together. This looks like what we were doing in the beginning. This little guy, no surprise, was not able to feed effectively, and his parents actually brought him to me after he had already had a release of his tethered oral tissues. But again, because that structure was not addressed, he still wasn't able to feed properly. Moving forward, the second thing that your baby absolutely has to be able to do is to use the tongue properly. There is so much talk about this now, rightly so. So your baby must be able to use his or her tongue to squeeze your breast tissue firmly to the roof of the mouth, his palate, in order to create that vacuum seal and to transfer milk. So let's talk a little bit about how that happens. We're not going to go through all of these ad nauseum. This is just if you need to refer and know the names of the muscles, and also just to prove to you that I know what they are. But there's basically 4 what are called intrinsic muscles. And what intrinsic means is that they originate from bone, they're attached to the bone, and then they extend to the tongue and affect all of the motions. It allows basically all of the motions of protrusion, which is sticking the tongue out, retraction, and side-to-side movement. So these are the muscles that are responsible for the main motions of the tongue that allow the baby to nurse properly and later on to speak properly. And again, we've seen this picture before a few slides back, but again, that take-home message is, guess what? Structure equals function. Again, I'm going to be saying that a lot. Look at where all of these tongue muscles are attached. Bottom of the mandible, okay, which is connected to the temporal bone, which is that TMJ, and they're all inserted here on that little styloid process. And we're going to talk about the hyoid in a moment, but it's a free-floating bone in the center front, in front of C2 and C3 in the neck. We've all seen little ones that have their head rotated severely to one side or another, very, very tight upper neck muscles. Well, guess what? That affects this hyoid bone as well, and functionally pulls down that tongue, can very much mimic a genetic tongue tie or what's called ankylosglossia. Now, let's not forget about how the tongue actually works, which is through the cranial nerve. What allows the brain to tell the tongue to do what it's supposed to do? Okay, so the main nerve to the tongue is called the hypoglossal nerve. It starts in the brain stem, and then it passes through a very small little hole called a foramen that is inside of the occiput. We're looking at the base of the skull here. The brain stem passes through this hole, what's called the foramen magnum, and the occiput here has a little what's called a condyle. You have to use your imagination. The first neck vertebra sits right at the bottom here. Okay, there's a little hole. It's called the hypoglossal canal, and that is where this very, very necessary nerve passes through and hopefully allows the tongue to work. If you look at this picture, it also shows how it travels down through the upper cranium, the upper neck. This is the neck area right here, and then it passes into the tongue. So from occiput, upper cervical, base of the skull, through the upper neck into the tongue. And once again, just imagine with all of that compression and rotation and the various imbalances that are possible in the baby's body, how this nerve becomes compromised. And this again is a possibility of what this looks like. In this picture here, these are two babies that I've actually seen in my practice and have, of course, gotten permission from the parents to use these pictures. This is that classic flat back of the head. We've probably all seen this, a very flat back of the head. And if you can imagine, again, look back at that slide if you need to look. The bottom skull bone is called the occiput. In this case, that occiput has been pushed forward. Okay, it's pushed forward, causing the flatness look to the back of the head. And in this case, again, the same occiput has been shoved backwards, giving what it's called a watermelon-shaped head. Sometimes we see babies that have a very long, narrow, elongated cranium, and that's what's happening here, is that occiput and the other cranial bones that are attached to it are being forced backwards, giving this elongated appearance. Now again, let's connect structure to function. It's not just a cosmetic, oh, your baby has a weird looking head comment. Remember what I said about that hypoglossal nerve that lives right in here, pulling this up, pulling this back. It very much either tractions or compresses that hypoglossal canal and affects the main cranial nerve to the tongue. Let's look at a few more muscles of sucking. Again, I love anatomy. So these are some of the main muscles that allow your baby to effectively use the muscles that move the jaw, that move the mandible. Um, I won't read through all of these muscles, but again, take home message connected to this is the bottom of the temporal bone. This is called the mastoid process. It's part of that orange bone that we looked at in the beginning. And this is also that styloid process, this is the temporal bone right here. They are connecting into, again, that hyoid bone in the beginning of the neck or in the front of the neck and connected into the bottom of the jaw. If this is misaligned, we see how all of these muscles are compressed. Same here. Structure equals function. Let's look a minute at the palate. That one is another really fun one to explain with the anatomy. As I mentioned in this number 2, your baby has to be able to use his tongue properly. Well, part of that sentence was he has to be able to use his tongue to compress the breast tissue tightly up against the palate in order to get that vacuum seal. Okay, so if the tongue is weak, that's difficult for sure. If the palate is excessively high, of course, we've all had those conversations probably about a high palate. That makes it even more difficult. I call that a double whammy in my office. So let's look at how that palate is formed and look at the anatomy to explain how that can also go wrong. So looking at, first of all, this simplified picture over here on the right, this, use your imagination, go back to the skull that I showed you in the beginning if you need to. This is the interior of what's called the maxilla. Okay, the maxilla has a suture down the middle of it in the newborn. That suture fuses as an adult, and this makes these two one solid bone. But in the infant, there is a suture. Sometimes it's called the cruciate suture. Sometimes we call it the intermaxillary suture. But the bottom line is that it allows motion in this suture right here and explains some of the misalignment that we see. This one is that sphenoid bone that we talked about. That is, this one, the red one, I'm getting ahead of myself, is a sphenoid. This one is called the palatine bone. So if we look again at that cranium and we flip it upside down, this is the interior of the cranium flipped upside down. This is the top row of teeth. This is the hard palate, which again is the maxilla. This is a bone right here that makes up the soft palate. It's called the palatine bone. And then underneath it is one that we talked about, the sphenoid bone. We see the temporals on the side here in kind of pinkish red, and this is the occiput. Okay, I think you're getting the picture here. It's all connected. These bones individually cannot shift, cannot move, which remember, they're very movable in the infant. These have not fused together yet. They cannot move separately. Everything shifts with it. So again, this is the palatine bone, sits right underneath the hard palate, soft palate. Okay, so as you can see here, bottom line, the palate alignment is really crucial in successful breastfeeding. It's so much harder for that baby to press the breast tissue against the palate if it's way too high. Let's see why it might be high. Okay, this is a picture of a pretty extreme, what we call a bubble palate, which is super, super high. The palate is kind of a complicated subject. There's many different ways that it forms. It partially forms in the womb from the tongue being able to press up against it. It continues to form as the baby gets a little older and is nursing properly and is feeding properly, again, from the tongue being able to press up against it. But we all know that the baby sometimes, as a newborn, has an abnormally high palate. Why is that? Well, again, let's go back to the anatomy. I need to introduce a joint here that we haven't really talked about. In order to do that, I actually want to go back a little ways. We're going to go back. Oh, there we go. This is a good example. The union right here of that, what's called again, the sphenoid bone and the occiput and the temporal bones, this right here is actually a movable joint. There is a little disc here, a rudimentary disc, and it allows for the bending of the cranium right at that joint. It can bend what I call flexion, and it can bend in extension. And I'll show you that in a second. Right here, this is what is called the spheno, because of the sphenoid, basilar joint. And the basilar has to do with the blood supply to it. But I won't go down that road. Spheno-basilar joint right here. So what happens, again, when that occiput, occiput bends down into what's called flexion. I showed you a slide a moment ago with that very long, elongated head, back of the head, and that usually looks like a very narrow cranium as well. The occiput is coming back away from the midline. That's forcing the sphenoid bone also back away from the midline, and you have to use your imagination. This joint comes up into what's called flexion. It comes up higher because of these two joints or these two bones moving away. Now let's look at that, what that looks like. Okay, actually I'm going to go back. Well, this is what it looks like, again, with that elongated occiput, the long head. That occiput has gone away from the midline. This little guy also has a very long watermelon head. I want to show you just a couple slides ago. Again, look at what's right there. This is the palatine bone. This is the top of it. Sitting right underneath is the palatine bone. So moving forward here, palatine bone is right there, right underneath this sphenobasilar joint, and it pulls it up. It pulls it up, causing that high palate. Let's talk just a little bit about those tethered oral tissues again. There's so much to say on this subject. I have hours of material in my other courses, and there is amazing research out there now that sheds a lot of light on this subject. We just don't have time in this little bitty course. So just for the sake of time, I'm going to simplify it a lot. There's basically two different types of tethered oral tissues. One is what we hear of so often, the genetic type. It's often called ankylosing, and what that is the shortening of the frenulum under the tongue. That band of tissue that anchors the tongue into the base of the mouth can be too short. The ankylosing technically applies to a posterior tie where that tethering is just a little more significant. These ties can also be at the cheek and gum level, and also can be under the front lip. That doesn't allow the lip to flip out and cover the breast tissue well enough for that latch. And there's lots of different reasoning or thoughts about why this is on the rise, one of which is a genetic mutation of a gene called MFTHR that has to do with methylation. That's going down a whole nother rabbit hole, but just so that you know, it is often thought of as a genetic mutation. Now you'll see here in that big bold box at the bottom that in the last 12 years, there has been an 835% increase in the diagnosis of this genetic form of tongue tie. And to go along with it, there's been that same increase in the surgical release of these tissues. Now, of course, the reason that I put it up there bold and in center is because that's a huge number. And if your brain is anything like my brain, I think, wow, is that really true? If there was an 835% increase in a genetic mutation in a period of 12 years, that would be the biggest genetic catastrophe on the planet Earth ever. So while this genetic form absolutely does exist, and studies show that it's probably about 25% of that number where it's actually diagnosed, what's really happened most likely is just that the neurobiomechanical portion is not identified. That, as we've been talking about through this whole course, the cranial spinal imbalance causes the muscle tethering, the tethering of those muscles of the tongue at the origin and insertion points, which means where it's attached to bone of the cranium and the neck. And like we showed with that hypoglossal nerve, the neurological interference that is getting in the way of that tongue muscle working properly. And this is just so often misdiagnosed as that genetic form because it's just honestly not in the education process of many different providers. Now, as you can see there also, what happens a good deal of the time is a combination of both. Like I said, that genetic ankyloglossia absolutely does exist. And those babies that have that genetic form, they all went through the birth canal as well. They all had to go through a often traumatic birth, and they too have that cranial spinal imbalance that is also affecting their function. So what I often see is that if the surgical release of those genetic tissues occurs, but the neurobiomechanical portion of it is not identified, then we still don't see an improvement in the breastfeeding function. Now let me say a word about release procedures. Sometimes my students think that I'm saying that I don't believe in the surgical release of oral ties and try to get a little bit mad at me. That is absolutely not true. The surgical release is oftentimes a very necessary procedure that can save the breastfeeding relationship of the dyad, which is the parent and the child. I work closely in my area with the release providers who are usually either pediatricians, ENTs, and ideally specifically trained pediatric dentists. Personally, if I'm working with a newborn for feeding dysfunction for 2 to 3 weeks, and I am not seeing significant results, then I always refer that baby to a qualified release provider for an evaluation of the genetic form of the ties. What I'm saying is that the neurobiomechanical portion of the tethered oral tissues should be addressed prior to any surgical intervention. And I'll say here too, that any release provider that is qualified, in my humble opinion, should be addressing this foundation as well. They should be referring to bodywork prior to any surgical release. Sometimes the frenectomy is not needed after the bodywork is done. Sometimes it absolutely is. Fortunately, the release providers in my area tell me and my clients that they have better results, have to release less tissue, and they see a better healing outcome when the needed bodywork has been done. And this bodywork should ideally be done pre and post any surgical intervention. Another thing to remember is that even beyond the feeding function, which of course this class is about, those imbalances in the baby's body can also lead to neurological and developmental challenges later in life. So I think that addressing these All of this first is crucial, not only to feeding, but to their well-being. Okay, now, moving past the tongue. The third thing that your baby has to be able to do in order to have successful breastfeeding is to have normal motion of, of the neck, of his or her neck. So your baby must be able to turn his head equally from side to side in order to comfortably nurse from both breasts. So let's just talk about upper cervical anatomy for just a moment. Again, big subject. We're going to keep it very brief. The upper cervical spine, this is C1, sits right underneath that occiput. Of course, this is an adult-sized head. I just couldn't find a good view of a baby head showing this same junction. Just imagine it much smaller. This upper neck, C1, C2, C3, sits right underneath that occiput, the base of the skull. Okay. Have you ever seen a baby do this? This is a classic presentation of what's called torticollis. You can imagine these neck muscles right here being very pulled. Okay. This is also very much due to that upper neck alignment. Okay. One classic symptom, if a baby has a torticollis or significant rotation of that upper neck, is that she struggles to breastfeed more on one side versus the other. You know, oftentimes your baby can't turn the head equally in both directions, and breastfeeding is just harder. Why is it harder? Just think about if your neck is out of alignment and sore. She's just really uncomfortable and cannot turn her head to the direction of the other breast to feed. Very, very common symptom that I hear all the time in practice. And there's the hyoid bone that I was telling you about. Hyoid bone, again, adult spine. Just don't have great pictures for the infant, but you can see this is actually a free floating bone. It's not directly attached to the spine, but is held there by ligaments, and it sits right in front of C3. Now, again, remember, this is much smaller in the infant. So C1, C2, C3 is very closely connected. Again, look at this picture here. Look at that little one. Just think about what those muscles are doing under the chin, connected to the hyoid bone. And once again, remember all those photos and pictures that I showed you. These muscles of the tongue are all connected to it. So you're seeing again that take-home message, structure equals function. You can just imagine these tongue muscles being pulled and tight because of their attachment to this hyoid bone and effectively acting like a tongue tie and even looking like a tongue tie. Okay, so pulling it all together. I love graphs and charts. I used to be a graphic designer. I like to have things to refer to. So this is what we've just talked about in summary. In order for your baby to be able to breastfeed easily and successfully, one, there has to be a nice wide latch. He or she has to be able to open the mouth nice and wide to take in all of that breast tissue as much as possible to access those deeper ducts. Then the baby has to be able to use the tongue properly to squeeze that breast tissue as tightly as possible to the top of the palate in order to create that vacuum seal and transfer of milk. And as we talked about, the palate can be an issue too in this particular circle. If it's too high, that's even harder. We also discussed the cranial nerves that are needed to be able to do all of this properly and for that tongue to be strong. And then again, there has to be a normal motion of the neck Baby has to be able to turn the head equally from side to side to be comfortable nursing from both breasts. And I didn't put that in this particular sentence, but also think about compression of that upper cervical spine, how it sits right underneath the occiput, and how that can also affect those cranial nerves. There are other cranial nerves that we didn't talk about. The main one called the vagus nerve. I imagine many of you who are listening to this are very familiar with the vagus nerve. That one also exits the cranium in the same area, very close by, right between the occiput and the temporal bone. And irritation or compromise of this nerve often results in just nervous system irritation. We see this as just overall very tight and tense body, colic, indigestion, hypersensitivity, and more. So this is just a very fun summary to explain what is going on with the baby. Now, before we're completely done for today, let's address something that is on many people's minds. Is this safe? For those of you who are not familiar with chiropractic work on infants, an unfortunate assumption is often that this is a forceful, quote-unquote, snappy poppy type of adjustment, similar to what you might see for the care of an adult, or, heaven forbid, some of the ridiculous things that you might see on YouTube. I want to leave you with this study. This is a very long and very thorough study done in 2016, and as you can see, I provided the reference for you here. I encourage all of you research lovers and professionals out there to read it thoroughly. I've just highlighted the main points here. This is looking not only at the safety factors, but also the efficacy, which means how well does this work? In this particular snippet, the authors compare the forces of pressure used by different types of common therapists that work with babies. They compared cranial sacral therapists, chiropractors, physical therapists, and what they call medical manual therapists. Now that one seems to just lump in many different things, but for the sake of not pointing fingers at anyone, I'll leave it vague. The bottom line here is that despite common misconceptions that chiropractors apply forceful pressure, this is just not true. Chiropractic and cranial sacral adjustments use very minimal forces, which are actually far less than other types of therapy, which are traditionally more accepted in the medical model. The chiropractic adjustment for an infant involves very light force, acupressure, and massage type work, which is focused in a very specific area and direction to correct imbalance. Later in the study, they also show that this type of adjustment was also the most effective in restoring the breastfeeding relationship. Now, I also want to speak to the non-chiropractors in the room here before I leave this slide and say that it's absolutely critical that you seek a specifically trained chiropractor to do this specialty work. Make sure when you're checking out a chiropractor to ask if they have been specifically trained in infant cranial work. I'm sorry to say that even if they have some general pediatric training, that's really not enough to address the cranial issues properly. Just like you wouldn't go to a podiatrist for help with your eyesight, please don't assume that all chiropractors have the same training. I will provide you with a good reference at the end of this course to find a qualified specialist. So here's a couple of pictures to show you. These are actually taken in my office to show you what that adjustment might look like. I love this picture for obvious reasons. Sometimes when the baby just isn't cooperating, we do deal with that. They are grumpy and hungry and tired. And yes, sometimes they're in pain because, like I said, they've had a lot of trauma sometimes in the birth process to this upper cervical area. Sometimes the only thing that comforts them during the adjustment is being able to be on that wonderful breast and feeding. So sometimes, with the parent's permission, obviously, I can do some of my work while the baby is at the breast, You see how just happy and content this baby is. This was a very fun session. This is another one. You can see how very blissed out and relaxed this little one is. She's sleeping through the adjustment. Again, it is a very, very gentle process. And here we go. Thank you for seeing me through this. Here's another sweet picture that I love as well. A tiny one. You can see how relaxed she is. And this is, of course, all of this is for the best care and the best life of our children everywhere. So I hope that this short course helped to explain some of the difficulties that your baby might be having. I do offer many other courses that do have continuing education credits for both chiropractors and lactation consultants on my website. You can see the name there, thegoodlifelearning.com. In order to find a chiropractor that is properly trained to do so, I am located in Davis, which is right next to Sacramento, California. You have my website there in case you're local to me. I would love to take care of you and your baby. And if you're in a different area, I suggest that you look up the ICPA, which is the International Chiropractic Pediatric Association. Their website is right here. And this is a good way for you to find a properly trained chiropractor in your area. Thank you so much for being with me. I hope that you have learned a lot. And again, it's so wonderful to just be able to help babies to breastfeed better.